Hello and welcome to a new type of series. I'm just going to be looking at the new articles that I find on my RSS feed here, and yeah, we'll just scroll through it quick, look at anything new and interesting. And as you can see, it's reloaded as of the last 17 hours. So yeah, this should be all pretty new stuff. So hopefully this should all be interesting. I'll just save any that I find interesting, and these are the sources I'm using. Here's the other feed. Basically, I'm using something called Feedly. It's a great app. I would recommend it yourself, for yourself. I'm not sponsored by them. I'm a bit too small for that for now, but I definitely still recommend them. Great, like distraction-free way of processing and getting new information. So definitely have a look at it. So let's get started. We've got this new thing. We'll start with the BMJ. I think it's just all BMJ then Lancet. So we'll look mainly because of the idea of this whole channel, the podcast. It's to do with new updates in medicine that will affect the patient. Okay, so some of this might not be relevant and therefore may be skipped over. If you find anything interesting, you can look it up. Okay, so let's start off. Here's the first thing that's caught my eye. We've got a new drug to treat resistant ovarian cancer. And it's the first to be approved over 2 decades. Okay. And it's called Mirvetuximab. Soravtansine. Okay. Bit of a mouthful. It's a targeted treatment. It combines a homing antibody with a cancer destroying drug. Okay. I wonder what these hearts. What does that mean? Oh, just definitions. Um, Often described by scientists as a biological missile or Trojan horse therapy, the drug is already available in the US and Europe. Sounds a lot like, the typical monoclonal antibody drugs now used for uh, ovarian cancer. I wonder if it is exactly that. It's in contrast to chemotherapy, it uses a targeted therapy that seeks out specific protein, FRA, folate receptor alpha, and delivers a molecule that destroys the cancer from within. Okay, fair enough. Let's have a look. Okay, so let's discuss this price. It must clearly meet nice guidelines if its benefit exceeds the cost. 4,950 per vial, definitely expensive. That's why it's probably in the abstract, actually, that price. It definitely seems to be marketed, but yeah, it's quite interesting. I don't need to look at the full article. That's because we've got a lot to go through, and also it is just to have a quick overview. So we've got Mirvetuximab, that's been approved for ovarian cancer. That's something we can discuss later, maybe in a future podcast episode. If you are interested in any of these topics that we're going to cover, uh, please comment below or email me directly even, and I'll take it into account and we can hopefully sort out some programming, maybe getting an expert to talk more about this new drug. Okay, so let's see. Safe maternity care requires learning from the full breadth of the staff and family experiences. Pancreatic cancer. Okay. Oh, it's even got a standing ovation. Let's see, because this is a very hard to treat cancer. That very famous for that. And let's see what it is. Daraxonrasib. I think that's how you say it. Why is it revolutionary? Lowest survival of common cancers because of how hard it is to treat. 5-year survival less than 7%. It's called Rasolute 302. That's the trial name. Pancreatic ductal adenocarcinoma. Yep, that's the one I thought they were referring to. Second line treatment, median of 13.2 months. That's how long they lived, the participants. Okay. While chemotherapy recipients are 6.7 months, that is a significant, that's basically doubled. And fewer side effects, results released at the annual meeting of the American Society of Clinical Oncology and published simultaneously in the New England Journal of Medicine. Prompted a standing ovation at the conference. I wonder if I can get a reader for this rather than... No, that's fine. They also mentioned that they had fewer side effects. That's important. Right. I think you have to log in, but that's fine. Let's go back. That's quite interesting. It's called Daraxonrasib. Let me save that. And let me save the other one as well. Where is it? It was somewhere here. Oh, right. The one that's grayed out. Okay. Now, next one. If you do think I've missed something that might be relevant to the podcast, please let me know. I'll look back at it in my own time. Yep, I know this. This is the new drug here, that similar naming scheme to Certolizumab Pegol, therefore will work the same way, pegylating. For SLE, yep, same purpose. Anti-Ra, anti-Smith and others. It starts in the third or fourth decade of life, much more frequent in women than men. In many people with the condition, SLE can present with persistent low-grade activity punctuated by flares. Others can be symptom-free between flares, and some can enter long-lasting quiescent phase. Okay, that's talking about the condition. What about this? So this is showing the trend analysis. It's very useful. But this is what it's mentioning. Shows steroid-sparing benefits, because in phase 3 now, isn't it? And now you've got efficacy and safety being mentioned. Yep, so very, very promising. It's saying this is the highlights. But yeah, this is the main one. Steroid use reduction and disease control in additional results from phase 3. Phoenix Go study is associated. So DZP, which is the drug, plus the center of care, was associated with sustained disease control at lower glucocorticoid doses through week 48, compared with placebo plus standard of care, supporting reduced long-term steroid exposure. Reduced flare rates and immune marker improvements as well. Very good. Okay. I'll save that as well. Next, let's think. That's another one talking about it. Save that. A lot of it is talking about the viruses that have been going on the cruise ship recently, and also the Ebola outbreak. Hantavirus is the cruise ship one. Microvascular. That's a comment. Coronary microvascular. No, wait. I know this drug. Tirzepatide is used for obesity. Yeah. That's the main one that the NHS has approved. So what's this talking about? It's for maintenance, and it's talking about the USA, so it's not relevant here. USA has stuck with Semaglutide, I think. UK has gone ahead with Tirzepatide because of its better effects. It just being superior. Let's look at this because this might be new. It's in South Korea. Suspected IHD undergoing invasive coronary angiography. Coronary microvascular dysfunction coexisted with epicardial coronary artery disease and was associated with a higher risk of the composite of all-cause death, myocardial infarction, clinically driven repeat revascularization, or hospitalization for heart failure. Okay. So this coronary microvascular dysfunction coexisted with epicardial coronary artery disease and was associated with a higher risk of the composite of all-cause death, myocardial infarction, clinically driven repeat revascularization, or hospitalization for heart failure. Yeah, that makes sense. Just highlighting the issues. Higher risk due to this coronary angiography that's invasive, which can cause this microvascular dysfunction, and that coexists with the epicardial, which means above the heart's coronary artery disease, and was associated with a higher risk of the composite of all-cause death. Fair enough. Okay. I don't think there's a need to save that one. It's an important comment. Some issues associated with this incretin-based therapy, GLP-1, GIP therapies, that are getting very popular. It's important to have these comments to show that not everything is going one way. There will be associated side effects. It's important for healthcare professionals and doctors to have an idea of what these are. Let's see if they'll give any right now. One of the main ones that I remember is how, regain after stopping the therapy. It's rapid and substantial because the habits aren't gone. They will regain 2/3 of the lost weight, and that's within 1 year of cessation. And if used privately, these are expensive drugs, so it may not be worth it. It is definitely an issue. It's why it's usually not the first line. It wouldn't be ever the first line if done properly. Talking about the USA here. First line for treating obesity would be diet and exercise. Transforming treatment, that's a perspective, but any articles here? We've got some. Ocrelizumab. Okay, talking about Ocrelizumab. I've not heard of this one. Another Zumab drug, okay. Zumab, I think, means completely murine, so completely from the mouse, derived from the mouse. Okay, let's look. It's superior to placebo in delaying disability progression in caused by multiple sclerosis, and it has a stronger effect on hand function. Okay, that's good. I think that's one of the first to go. Please correct me if I'm wrong, and don't judge me if I say that. Use the pro feature. I am just using the basic Feedly in a broad PPMS population, including older patients and those with more advanced disease, while maintaining a manageable safety profile. Nice. So what's this next one? Efficacy and safety. Okay, just talking about the efficacy and safety of a higher dose of Ocrelizumab in relapsing. That's this trial, and primary progressive multiple sclerosis. 2 multicenter randomized double-blind parallel group phase 3b trials. End stage, very good. In both studies, it did not further. Okay, so is tapering off quite quickly. That's important to know. No new safety concerns were identified. Okay, so even if you do increase while it doesn't have any effect, it doesn't have any significant effect. It doesn't have any side effects as well, new side effects. Okay. Is this important? Alzheimer's disease, neuropathology, plasma biomarkers, and cognition in midlife, a community-based cohort study. It's a cohort study, so this is disease, neuropathology, plasma biomarkers, and cognition. What have they found? So it's saying with worse cognitive performance and accelerated decline, that's what it's associated with Alzheimer's disease. It might also have a stronger association among some groups. Early Alzheimer's disease neuropathology detection with the use of plasma biomarkers might enable timely prevention and intervention in midlife adults, including risk reduction and pharmacological therapies. With the use of plasma biomarkers might enable timely prevention and intervention in midlife adults, including risk reduction and pharmacological therapies. Okay. So if we detect Alzheimer's, if our process of detecting Alzheimer's also included plasma biomarkers, it may make prevention occur earlier on, and that can reduce risk and make these more effective, the pharmacological therapies. I'm assuming. More to read later, but where has it gone? Also, where's my red articles? Oh no, they're here. Let's get that saved. And Ocrelizumab as well. Okay. That's nice. Okay, and let's see what else is there. So a lot about Alzheimer's. Let's just go a bit more into it because even though this is only comparing two people, I think, what is this referring to? Within participant study. Compared with Flotaucipir, MK6240 identified more individuals with tau pathology in cognitively unimpaired and cognitively impaired individuals, with direct implications for patient stratification in clinical trials and more precise guidance for therapeutic decision making. Oh, so this is another way of screening for tau proteins. Okay, that's interesting. I'll put that on. There was another one on just next to it talking about dementia or Parkinson's. Efficacy and safety of IV Prasinezumab in individuals with early stage Parkinson's disease on stable symptomatic monotherapy. A phase 2b multicenter randomized double-blind placebo-controlled study, so pretty literally up there. There's nothing much better than this, except for a meta-analysis. So it did not meet the primary endpoint. Pre-specified exploratory evidence does suggest, however, clinical activity of prasinezumab in early-stage Parkinson's disease. Safety and efficacy of Astegolimab for COPD with frequent exacerbations regardless of baseline blood eosinophil counts. I wonder what the primary endpoint was. Is it literally here within the title? I don't know what they're referring to by the primary endpoint, but probably just their goal of what they wanted to achieve with this. It did not meet. Okay, so the trial must have been cut short. That must be what it means. But it did show evidence that did suggest efficacy. So then continued investigation in the ongoing phase called the 3 Paraiso trial will be happening. That's an interesting one to keep a lookout for. Let's save that. I've not heard of this one. I've not heard of pretty much everything anyway, but let's look at this. Every 2 weeks, Astegolimab was associated with a lower annual rate of exacerbations versus placebo in patients with COPD. A lower annual rate of exacerbations. That's good, because you can get plenty with COPD, and a history of frequent in patients with COPD and a history of frequent exacerbations. So people who already had plenty of exacerbations quite frequently, they were given this Astegolimab every 2 weeks, and that was associated with a lower annual rate of exacerbations. I wish they gave the stats immediately, They said that it doesn't meet statistical significance, so while it did show some promise, it's not showing too much now. Together, these findings suggest a role for targeting this pathway, even though this drug specifically, it might not do it so effectively. There might be alternatives that do target the same pathway and achieve this response of reduced or COPD exacerbations. Yeah, they'll have pretty limited treatment options. It's a chronic disease that will get progressively worse and potentially difficult to live with over time. And especially if the patient does not stop smoking, for example, if that's what the cause is. Okay, let's move on and let's look at more things. This will be talking more about the things that are relevant. Let's see. Relevant to the public, I mean. It's a seminar, and if it's relevant to the public, it's relevant to health professionals. So it comes from that kind of perspective, the BMJ. I think. That's what I'm seeing. They will still talk about things that are directly relevant to healthcare professionals, like new medical updates. Let's see. Endovascular thrombectomy for patients with large core ischemic stroke presenting up to 24 hours after onset. It's a systematic review and individual patient data meta-analysis with central imaging adjudication. Endovascular, within the vessel, thrombectomy, removing of the thrombus for patients with large core ischemic stroke. What is large core? Ischemic stroke just means a stroke which has occurred, for example, due to thrombus that has now reduced perfusion of blood and oxygen and therefore the nutrients, blood and therefore the oxygen and nutrients to the tissues of the brain. Large core, I'm guessing, is the center of the brain. Large core ischemic stroke. What did I just click on? The website? Let me just look at what large core ischemic stroke is, if I can type. It's anything with aspects less than 6, or an infarct core volume of greater than 50 milliliters. It accounts for more than 25% of ischemic strokes that present at hospitals. That's fine. Endovascular thrombectomy was associated with improved functional outcomes and reduced mortality in patients with large core ischemic stroke. So this just confirms that. And that's presenting within 24 hours of onset, which should be the case because stroke is usually is an emergency situation. Then if it was greater than 150, that shows extensive ischemic changes. And that presents, and it also has to be a presentation beyond 6 hours, where evidence remains limited because that would be very late intervention. Benefit was sustained across aspects and ischemia score strata for patients presenting up to 24 hours after onset. That's good. Okay, I actually want to know more about this core volume. Is that talking about... No, I don't want to guess. Let's see. Infarct core volume. Let me just search this up. Infarct volume, you can see here in Science Direct, is defined as the volume of brain tissue that has died due to insufficient blood supply. Okay, so large core just means a lot of that brain tissue has died because of that insufficient blood supply. That makes sense. So by getting into the veins, the vessels, sorry, not the veins, and removing that thrombus, which is the clot, and causing that stroke, even if it's a large core one, which means that more than 50 milliliters of volume of that core volume is affected, it can still show improved functional outcomes and reduce mortality versus typical medical treatment. Yeah, that's very interesting. Actually, I'd love to know more about this, so I'm definitely going to add that. Okay, that's going to be I wonder if I could prioritize that. I do not know. For now, I'll just keep it in my head. Quite typical, isn't it, to provide these two to reduce the effects of osteoporosis and fractures in elderly age, especially in care homes. Yeah, nursing homes right here. So this might be giving some additional information or a review. Admission to hospital because of fractures leads to functional decline for many. 17% of older adults admitted to hospital for a fall in Canada subsequently require admission to long-term care. Yeah, it's really difficult to treat broken bones in elderly patients, isn't it? Especially if it's a leg fracture, it takes even longer. In a healthy person, it takes 3 months already. Roughly, as far as I know, at least. Increases, obviously, that's probably subject to a lot of factors. Increase in full. Yeah, aging population, therefore, you'd have more of these fall-related deaths and disability is associated with them. There needs to be a lot of investment made, both commercially and through the health sector. I think it's already being done to a very large extent, but if we look more into this sort of stuff, this is actually very useful. The articles like these for the managerial side of things in terms of what to invest in. Show something like this to NICE and it might be helpful. Getting a better picture of the actual intricate effects of the aging population. And that's what they're talking about. Look, all these factors that contribute to it, they can all be targeted. That can contribute to fall risk. I have actually thought about fall risk for a while, especially when it comes to women. It's much more common. They're at higher risk after menopause. So definitely, I keep asking this question. Definitely want to talk to someone about this. So about what interventions can be done in a holistic way, but also on a national scale as well as a local and individual scale. What interventions can we introduce? So it shouldn't just come from a health perspective, but for example, if a child is taking care of their parent, or maybe if a volunteer is working at a care home or a worker at a care home, or even nurses who are going around the wards, are there any interventions? That's my question that I would love to ask. Are there any interventions that they can do, that they can put in place, and we can cover one by one? So this is definitely something I want to cover. People will have fractures, they'll lose blood, their body won't be able to support it because they're already frail. So yeah, it says here, with low body mass index, low bone density increasing. Very important article. I'm happy I came across it. This is why I absolutely recommend 3D. Here we go with PMOS. It's changed from PCOS to PMOS, and PCOS is uh, polycystic ovarian syndrome. This is polymetabolic ovarian syndrome. Reason for the change, I've done a bit of research in this, is because of it being a more endocrine disorder. Cysts are like a specific sort of characteristic of the disease. It's not the entire syndrome. So that's why this is a lot more of a holistic name. It will allow for more people to understand what it is, especially makes it easier to, I guess, explain it when breaking bad news or sharing significant information. Doctors, GPs, or whoever the carer is, they can explain it to a better extent. And this will also encourage more understanding of the syndrome itself. It's a very misunderstood syndrome, misdiagnosed syndrome, or missed syndrome in general, because of the associated symptoms. So knowing that it's a disruption to the hormones like luteinizing hormone, and there'll also be issues with testosterone, that will make people have a better understanding of exactly what the pathophysiology of this disease is, and hopefully it will encourage more research. It should also encourage more people on an individual level to be more clued up on what this actually is. calling it PCOS instead of PMOS would be indirectly causing that harm because of misdirection, misunderstanding. Yep, the wrong story. Patients pay the price, like later diagnoses, for example.